Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Naha Balada from Roots Community Health Center reporting for the week of February 13th, 2023. After an update on COVID, I'll review some new data on the vaccine and on COVID treatment. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Looking here at the New York Times Interactive Hotspot map, where the warmer colors indicate higher average daily cases per 100,000 people in the past week. We can see that there are still increasing cases in Austria, New Zealand, and Samoa. Sadly, this coronavirus world map tracking and the Johns Hopkins tracker will be archived on March 10th as global data on cases and deaths will no longer be reported. So this is unfortunately another resource that will be going by the wayside as choices are made to stop tracking and monitoring what remains a global pandemic. Across the U.S., we're generally continuing to see some improvement, although over 80% of U.S. counties are experiencing high or substantial community transmission. Here in Alameda County, total cases over the previous 14 days is currently increasing. A week ago, we were at about 1,500 cases. Now we're a little over 1,800 cases over 14 days. We know that this is a significant undercount, but still don't like to see the upward trend. Also, when we look at the rolling 7-day % positive PCR tests, we continue to see increases week over week. Last week, we were at 6%, and this week we're at 7% test positivity. Taking a look at our wastewater, after a few weeks of trending upward, we do seem to see a slight downward tick here. So hopefully that will continue. Hopefully that will be then followed by a decline in cases. Hospitalizations are about the same as last week, with one less person in the hospital, but one more person in the ICU compared to last week. We're learning more and more that hospitalizations are a very difficult metric to track and to rely on because sometimes people come in with the infection. Sometimes they can even catch it while they're at the hospital. They may be in the hospital for other reasons, and the infection may exacerbate those other reasons. So we believe that the hospitalization numbers are a mixture of people who are there only because of the COVID and others who may be also dealing with other issues that might be exacerbated by the COVID. I want to mention that California has remained a leader in terms of maintaining requirements for masks in healthcare facilities, and I'm truly hopeful that this will continue. With the ending of the public health emergency, which remember is an administrative action that does not in any way signify the end of the pandemic, but some of these protections are in jeopardy because of the ending of the public health emergency. New York State has already removed masks in healthcare settings this month, which will leave patients vulnerable to getting infected. People go to the hospital to receive treatment, not infections. So as long as we're in a pandemic, I firmly believe that masking in healthcare should remain. And if you agree, please consider taking action. There are some recommendations listed there in the post. So it is beginning to seem like the most reliable metric we can look at, unfortunately, is deaths. And we know that deaths remain an undercount because this does not account for people who might die from a post-COVID event or a long COVID condition. We also know that sometimes people who may die at home or in a nursing home may have other conditions, so it might be difficult to know if the death was from COVID in those settings. So even though it is an undercount, we know that confirmed COVID deaths means confirmed COVID death. A person had to have died from COVID, or COVID was a significant contributing factor to their death. And I've heard some misinformation and disinformation out there about these death counts, but I can tell you, as someone who's unfortunately had to complete death certificates, that physicians complete these death certificates to the absolute best of our ability. We don't make things up. These are legal documents. We have absolutely no incentive to say that it's one thing or another. So if we put that someone died from COVID on the death certificate, then that is the most accurate information you are going to get on that individual's cause of death. So these are confirmed deaths. And though they are an undercount, we are currently at 390 average deaths per day. This is down a little bit, which is good. But remember, we've really been hovering somewhere between 300 and 600 deaths per day for coming up on almost a year now, ever since we came down from the Omicron surge, and we've just never quite come down far enough. And even though it feels like 2023 has just begun, we've already lost 21,378 people to COVID-19 in the United States so far this year. And you can see here the weekly death totals. And again, so far this year, over 21,000 people have died from COVID, not counting post-COVID, not counting long COVID deaths. Now, taking a look at variant proportions, XBB.1.5 continues to rise, projected to be comprising nearly 75% of samples nationwide. The good news is that the CH.1.1 has actually decreased. Remember, that was the one that had some concerning mutations we were keeping an eye on. It was 1.6% last week. Now it's projected to be down to 1.3%. So that's a positive development. However, we do know that XBB.1.5 is extremely contagious, the most contagious variant we've seen yet, and it is quite immune evasive, getting around our prior immunity and around some of our tools. XBB.1.5 has almost completely taken over in the Northeast, and it's increasing all across the United States. It's now the dominant strain in every part of the country except in the Northwest. And when we look again at the community transmission map, the pattern here does seem to mirror the variant transmission, the variant proportion map, in that those areas with the least XBB.1.5 also have the lower community transmission in general. So it remains to be seen whether this increase of XBB.1.5 will drive any significant waves here in California or in other areas where it is becoming dominant. Now I'm going to turn to this recent article published in The Lancet on February 10th, reviewing some real world data on the COVID treatment Paxlovid. I thought this article was important for a few reasons. One is that the study was done during the time of Omicron, so this gives us insight into how the treatment is working in an Omicron environment, since the original studies were pre-Omicron. And second, it's always important to get real world data to see if the results from the clinical trials hold up in the real world. We expect to see some differences under real world conditions. And as time goes on, we will continue to see more and more of these types of real world studies that will help to shed more light on COVID prevention and treatments. This study looked at over 21,000 individuals infected with SARS-CoV-2. Over 9,800 of those received treatment, and over 11,600 did not receive treatment. And what they found was that the reduction in hospitalization and death were indeed significant. Over 80% reduction in death, over 50% reduction in hospitalization at the 28-day mark. What I also thought was important about this study was that they attempted to look at this phenomenon of relapse, which has been called rebound in the media, and unfortunately has been used as an excuse to not get treated or to not prescribe Paxlovid, which is potentially a deadly mistake. I reviewed the phenomenon of relapse in a prior briefing in detail. The link is in the post. The bottom line is that it does appear that the natural course of the virus can include rebound, whether you take treatment or not. And if you do take treatment, it can happen regardless of what treatment you take. So remdesivir, molnupiravir, Paxlovid can all result in rebound, or even not getting treated at all can result in rebound. So I think because so many people have received Paxlovid and noted this phenomenon of rebound, Paxlovid has kind of gotten a bad rap over it. And I think this is a big misunderstanding that absolutely we have to educate ourselves on, so that we don't have any more unnecessary deaths due to withholding life-saving treatment. So what this study did was use emergency department visits as a way to assess for relapse that was clinically significant. So it would have had to been a significant enough relapse to take the person to the emergency room. And they found that actually more people who didn't get treatment had clinically significant relapse that took them to the emergency room. So once again, more people relapsed with COVID and it took them to the emergency room in the group who did not get treated than in the group who did get treated. This is critically important. Now, once again, this is real world data. So this is what we call an observational study. So it's not a randomized trial like the one that we had in the original clinical trials, but they did do their best to match the group so that we would be as much as possible comparing apples to apples. And even in trying to do that, the treatment group was still older in age and still had more people with 2 or more chronic conditions in the treatment group compared with the untreatment group. And this just probably has to do with the fact that more people who are older and sicker are getting treated. But what this also says in terms of the study is that the findings are even that much more significant because treatment reduced hospitalization and death, even though the group that was treated was older and sicker. So we see a significantly lower odds of hospitalization for people who are treated, a significantly lower death rate in those who are treated. And this graph is just looking at the subset of people who are hospitalized. So that's just 61 people in the treatment group and 135 people in the non-treatment group, the untreated group. And the untreated group there on the left, I'll just draw your attention to that red bar at the bottom there. Those are deaths. And so we can clearly see that being treated reduced the risk of dying. So Paxlovid is reducing hospitalization and death, and the risk of rebound or relapse is worse if you don't get treated than if you do get treated. So please, let's all do our part of not spreading this confusing and continued disinformation that Paxlovid itself causes rebound. Rebound happens with treatment. It happens without treatment. It happens with any of the treatment. It's just part of COVID, unfortunately, and it is generally not clinically significant. I know it feels significant if you were feeling better and then all of a sudden you now have another positive test and you're not feeling well again. But guess what? You're not in the hospital and you're not dead. And at the end of the day, that is why we are giving the Paxlovid, is preventing hospitalization and death. And that is exactly what it's doing. And to have clinical trial findings be essentially replicated here with real world data is very reassuring. There's another recent study from Canada that basically demonstrates the benefit again. And I linked that article in the post. I'm not going to go through that one in detail today, but I think the evidence is fairly clear at this point. If someone is at risk of a poor outcome from COVID, which includes basically everyone over 50 and everyone with any kind of chronic conditions, then we need to be getting them treated so they don't become another COVID fatality. These deaths are now largely preventable with timely treatment. So let's get the treatment and just accept the fact that there could be some recurrence of symptoms after the treatment is over, but that can also happen even without the treatment. So this is a non-issue. And remember, the sooner we start treatment, the better. We are not waiting to see how we feel. That is not how this works. If you wait, it could be too late. Next, I want to go over some real world vaccination data. And this is another area where I think we can expect to see more and more studies coming out to assess the effectiveness of our vaccines over time and compared to one another and compared to infection plus vaccine and so on. This recent publication, published February 10th in the Lancet, attempted to look at vaccine effectiveness over time. Now, this evaluation was a meta-analysis. So that means it looked at many different studies in order to draw its conclusions. And this meta-analysis ultimately included 68 studies for analysis. And what they found was that the vaccines were quite effective in the short term, and then the effectiveness started to decrease over time, which I think we already know, but this analysis actually helps to quantify that. So let's start with effectiveness against infection. We all know that you can still catch COVID even though you're vaccinated. So we already know that vaccines don't stop transmission. Actually, very few vaccinations can completely stop transmission. But what they found is that for the primary series, the effectiveness was 83% for the first 6 weeks or so, and then it dropped to about 62% by the 140-day mark, so a little less than 5 months. So it went from 83% effective for about the first 6 weeks, then down to about 62% around the 5-month mark. When it comes to the booster dose, the effectiveness was about 70% for the first 10 weeks or so. Then it reduced to about 43% by the 4-month mark. So when it comes to infections, we get pretty robust protection initially, and then it declines fairly significantly after that. Now, moving on to hospitalizations, the primary series was found to be about 92% effective for more than 3 months against hospitalizations, and then it went down to 79% at the 251-day mark. So for over 8 months, we're still talking about nearly 80% protection against hospitalization. And when we looked at the booster, we saw approximately the same thing, 92% protection initially, then dropping to about 79% by about the 8-month mark. So this is still fairly robust protection against hospitalization, but for about 8 months. And lastly, looking at protection against death, we saw that for the primary series, protection against death was 91% for the first 3 months. Then it reduced to about 86% up to approximately 6.5 months. So again, still fairly robust protection, 86% for about 6.5 months, but only for about 6.5 months, which is how we're ending up with these booster recommendations that are seeming to come about every 6 months. They did try to assess the difference between the mRNA vaccines and the adenovirus vaccines, so like the J&J and the AstraZeneca. Overall, the mRNA vaccine effectiveness was higher, but there were fewer adenovirus vaccine studies, and very few are comparing anything head-to-head yet. So this is still a very difficult comparison to make, and there were no studies looking at the Novavax. So hopefully as time goes on, we'll get more of these head-to-head comparisons, but right now we just don't have those. So basically here we have a very large meta-analysis looking at 68 different studies. And even though there were differences from study to study, the overall pattern really remains the same. And that is that vaccines are initially great at protecting against infection, hospitalization, and death. But then the effectiveness against infection drops off really significantly. It's not enough. And protection against hospitalization and death do appear to hold up well for about 6 to 8 months, which is great, but also it's not enough for this effort we're trying to make towards an annual booster. So as long as we keep having such high rates of spread, we're going to keep dealing with variants, which may get around vaccines and treatments. And with the vaccine not preventing transmission, this is just sort of the situation we're currently in. So I think the bottom line is we're really going to need better vaccines that do a better job of stopping transmission and hopefully have more long-lasting protection against hospitalization and death. But until then, we're really going to be continuing to look at data like this to figure out what is the best way to approach the booster plan. Based on these studies, it would not seem sufficient to have just the annual booster for people in those higher risk categories. So maybe we'll be looking at more like every 6 months or so for those in the high risk categories. So we'll just have to continue to monitor the updated recommendations. For now, vaccination does remain our best protection against hospitalization and death. There's just no doubt about it that the risk of hospitalization and death are several-fold higher for those who are not vaccinated. And there is not substantial or durable protection against infection after vaccine. So even this study suggests that because of that, other mitigation measures like using masks would be needed in order to reduce spread. So with over 21,000 people just in 2023 alone already who've lost their lives to COVID-19, we need to make sure that we're properly using the tools we have. Definitely, if you're at risk of a bad outcome, if you catch COVID and you've not gotten the bivalent booster, now is still a great time to go ahead and get it. And just as this study suggested, that is not going to take care of things all by itself. We're going to need those multiple layers of protection. And unfortunately, those layers seem to be disappearing before our eyes. Fewer and fewer people seem to be wearing masks. We're getting some reports of super spreader events. And at least anecdotally, we're definitely hearing of people who've avoided catching COVID all this time, catching it now for the first time because they've let their guard down. So I just want to reiterate here, there's actually no objective reason at this point why we would be letting our guard down. None at all. In fact, you could argue that we should be increasing protection if we don't want to catch COVID, because everywhere is starting to drop mitigations, the few that still existed. And remember, the ending of the public health emergency is an administrative decision. It does not signal the end of the pandemic. Remember, the World Health Organization has reiterated that COVID remains a public health emergency of international concern, and COVID is still circulating. There are still many unknowns about the long-term effects of COVID infection. What we do know is that there are long-term effects. We don't know who's going to experience them and to what extent. It does not seem to correlate to how severe your initial infection is, and it does seem to increase with each COVID infection. We still have no treatment for long COVID. We're still learning. We're still in the early stages, honestly, of learning about long COVID. And we're still losing hundreds of people a day to COVID. So please do what you can to avoid getting infected or reinfected. Gather outside, improve air quality, wear a high quality filtration mask like an N95 or KN95 or KF94. Please use rapid tests for pre-event testing. If you get exposed or if you have symptoms, repeat the rapid test every day or two while you continue to wear a filtration mask, or go ahead and get that more definitive PCR test, especially if you're someone who would be treated if you're positive. Remember, the sooner the better. And the days of showing up to school or work feeling sick and exposing others should be over. Stay home and rest if you can. But if you insist on going out, wear an N95 mask. It is considered source control. It will keep you from sickening or even killing another person. If you do not have a primary care provider, please get one. Know how to reach them before you need them. Make a treatment plan with them. Have them tell you, are you someone who should get Paxlovid? And if not, you need to know the reason why. This is a life-saving medication, and we don't want to be using flimsy reasons that have no basis in reality, like this rebound factor that's not clinically significant at all. This is a non-issue. So let's not let that be a reason. If you're someone at risk of a bad outcome, you should be treated. And if you're not up to date, please get up to date on your boosters. Get that bivalent booster. If you didn't want the mRNA vaccine, please go ahead and get the Novavax vaccine. And remember to eat a balanced diet, consider a multivitamin supplement, consider getting those vitamin D levels checked to see if you need supplementation, get some regular exercise, some fresh air, get a good night's sleep, and manage those stress levels. This concludes today's People's Health Briefing. Thank you so much for joining us. We will see you again next Tuesday at 10 a.m.